Right. Good morning or afternoon, depending on where you're joining us from. My name is Carson Hetty. I am an account executive with Microsoft in St. Louis. Certainly appreciate you joining today. Definitely hope that this session finds you and your loved ones and your colleagues safe and well during these trying times. This is a very timely topic today. Recently, one of our gold partners, KenSci, in conjunction with Microsoft HealthNExT, has created this real-time command center for COVID-19. It has the abilities to predict and track hospitalizations, also inventory, and find at-risk patients in real time. So it's very valuable for hospitals and healthcare providers in this time. And we're also joined by one of our special guests, John Bartow, who is an industry executive at Microsoft in the healthcare segment. So that said, I'm going to turn it over to Sunny at KenSci so he can begin the presentation and talk a little bit about how quickly the solution can be set up and the special offer that KenSci has around these services. So Sunny, the show is yours.
Thank you so much, Carson. Thank you everyone for joining. And I wanted to thank you, those who are in the front lines of responding to COVID. We are all here to help you, right? You are the digital first responders, as Satya Nadella was saying the other day. And I think that is such an apt definition of what so many of us are going through. So we are in awe of all that is happening. So, I wanted to share with you what we are learning by helping some health systems, and I'll name some of them across the coasts, respond to COVID in real time, both from a hospital administration perspective as well as a population health point of view. And to do that, we have with us John Bartow, who's a healthcare evangelist with Microsoft. And I am the Chief Growth Officer at KenSci. I head up our partnership with Microsoft as well as our relationship with customers. And what we wanted to talk today for the next 30 minutes or so is essentially four parts, right? I think, honestly, this got all of us on the wrong foot, right? So, we had to race to respond to this. We are racing to respond to this. All of us, most of us are having, very long days, 7 days a week. And I wanted to kind of share, what are those, fundamental things that are in retrospect broken and how people are gap filling them, right? Then the second part and the third part, I want to talk a little bit about what's going on with the state and local governments as well as some of the large health systems, how they are thinking about this as a systems problem, right? Saying, how do you think about this as from a capacity planning? How do you think about this from a population health and outreach for those who are most vulnerable and that sort of stuff? And then we will talk a little bit about what's going on inside the hospitals, which are sort of ground zero of this response. And it's chaos, and that's the truth about it, right? I think people are doing heroic stuff, especially the doctors and the nurses and administrators, but it is a really, really hard time to be inside a hospital at this point, not just from a clinical perspective, but also from an operational perspective, right? So I want to spend a little time on the operational aspects of it, the clinical stuff. There are a lot of amazing people responding to that. So I don't want to go deep on what the doctors and nurses are doing from a clinical decision support perspective, but at least, making sure that the beds are available and ventilators are available and, the stuff and the staff are moving to the right place at the right time. So we'll talk a little bit about that, right? And then finally, I want to take this opportunity to reflect back a little bit for brief 5 minutes to just think about what happens after this surge dies down, right? It's unlikely that this is going to be a one-off, once in a lifetime scenario. It's likely going to happen like earthquakes, right? It will happen, we just don't know when it will happen, right? So what can we do today so that we are ready for this tomorrow, right? How does life go back to normal or some semblance of normal? What happens to elective surgeries that have been canceled, right? People still need to replace their hips and knees and hands, right? So what happens when you pack 12 months of surgery in 6 months, and what stress does it create near term, right? So that's what we want to talk about. But before I go there, I want to hand this over to John, because John has been in the forefront talking to over hundreds of health systems from Microsoft, helping them respond to COVID. So I wanted to give John the opportunity to share what he is seeing, what he is learning from the digital first responders. John, over to you.
Thank you, Sunny. Hey, I joined Microsoft nearly 10 years ago. It'll be 10 years in December. And the purpose of joining Microsoft is I actually came out of the healthcare industry. I'm a former CIO from a hospital. Sometimes I say recovering CIO from a hospital. And one of the things that I came to Microsoft for was to help organizations transform their business in the healthcare space based on technology, which I didn't see is growing very heavily in healthcare over the years. And what's fascinating to me is I've been here nearly 10 years, and I think I've seen more innovation in the last 7 to 10 weeks based on COVID than I've seen maybe in the entire 10-year period. And I think a lot of that is because people have laid down their armament around how we want to sell various things and do various things, and just picked up the capability of helping humans survive this pandemic. And there's been a lot of effort going on in that space and a lot of innovation. And we've seen things from deflecting cases from coming into the health system to determining when the surge is going to happen and how do we allocate the precious resources, be those ventilators or even drugs that are needed when we actually ventilate someone and stuff like that, or the PPE and how do we get donations from other places. So we've seen this develop all over the globe where unique technologies are coming to bear to help out these organizations. And I think it's the first time that I've really seen a real integration of technology folks working directly with frontline folks in the healthcare space, solving problems, and that's how this innovation has occurred. It's sad that it took a pandemic to do it, but what we're seeing is a lot of contribution from the technology organizations, not just Microsoft, all the other large players in this space, to helping people get through this pandemic. And I'm just really proud to see how our partners have come to the table in this space. And I really like this offering that KenSci has, because basically what it does is it puts you in a position of being able to manage what you need to manage as a healthcare system. And it doesn't have initial cost to it. And that's what a lot of our partners in Microsoft's doing, is defraying the cost of these solutions so that you can actually adopt them and not have to worry about where's the money coming from for them. As Sunny said, when elective surgeries go away, a lot of the hospitals' profitability kind of leaves as well. And so we want to make sure that we're doing our part in this time. And so, Sunny, if that's good enough for you, that's what I'm seeing across the board. And we're seeing outrageously creative solutions, things like telehealth visits, ramping up to 4,000 times what it was before, and that may become the new norm. And we're seeing all kinds of different things go on in these health systems. And I just wanted to give you a few minutes of what I'm seeing and the rush we're coming after this with. But I love the way humans are working with humans trying to solve this problem and not looking at what's the business aspects of this thing. And I love what you've put together here, Sunny. So I'll turn it back to you unless you have any other questions for me.
Thank you, John. Yes, and we will, pull you in for more commentary as we go down the road. And, very aptly put, John, I think the pace of innovation that we are seeing now is incredible. I think, I remember this quote from Lenin, of all people, where he says that, there are decades when nothing happened, and then there are weeks when decades happen, right? I think the month of March was a decade in terms of just the pace of change that's happening across the board, right? So I think with that backdrop, I want to kind of shift towards what is that change that's actually going on the ground, right? So, just a brief bit of background before I go into this proposition or the offering, right? We have been working with Microsoft HealthNExT, really trying to embrace the Azure API for Fire platform, right? Because we saw that as a future for the way, customers and partners would share data, bring it all together in one standard format. So we built a data pipeline on Azure from a purely technical infrastructure perspective. This was supposed to launch at HIMSS, right? And then HIMSS never happened. But what that, and then COVID happened in that time frame, right? But because we had that pipeline on a standardized data format, we could very, very quickly build all this that I'm going to show you, right? And to be very honest between all of us here, right, we did not have this a month back. Nobody had anything to do with COVID as an offering or anything like that a month back, right? All this that you are seeing today that's going live today, whether it's, crazy amount of usage of cloud or usage of Teams or usage of telehealth or new solutions coming to market for, tracking everything, all this is getting done in the last 30 days. And I kind of want us all to consider that as a norm going forward. If we can, it's not that healthcare doesn't innovate, it just requires the right triggers, right? And I think the biggest trigger here has been, for us at least very personally, has been, taking an approach that says we are going to standardize on a data format, which is, Fire, and standardize on an infrastructure so that we can keep innovating and reacting on the application front end very quickly, right? So, so that's sort of the little backdrop. So let me walk you through what exists today. We are building this out. This is live at St. Luke's University Health Networks, with whom we did a webinar. The CMI of SLUHN and us and HealthNExT did a webinar yesterday. It's going live on HIMSS today. So you can hear from a CMIO as to how they're responding and how this is helping in part towards that. This is also live at a few other health systems down south. We are working with the Chicagoland team to help respond to what's going on in Chicago from a state, local, academic medical center, as well as commercial medical, clinical side perspective, and bringing everybody together, saying we are in this together. How do we solve for this, right? So my point being, this thing is live, this is working. There are people talking about how this helps them. But that said, there is a lot to be done on this, right? We have I would say a version 1.2, right? There are 10 more versions that we might have to build going forward. As long as we are open to innovation and open to having this on a standardized platform, the application front end is relatively simple. And so with that said, let me quickly walk you through what is being used today, right? So there are going to be two parts to this. One is the surge capacity planning. The other one is community risk management. This is to just to focus people on, this is what's happening outside the hospital, what the hospital administrators or the IDN leaders or the payers are thinking about, right? So where we started was we took the Johns Hopkins data, put this on Power BI. This thing is up on Power BI gallery, free for everybody. So there are hundreds of this. NYT has an amazing view of this, which is built our own on Power BI. This gets refreshed all the time. It's freely available, right? But we took that data and then zoned in on a county level, saying in this county, at this rate of infection, when do we run out of beds? And then we are marrying that data with the health system data, saying, look, we have 75 ICU beds, right? And we have our average length of stay is 5 days, right? For our population. What does it mean for us in terms of how many we need on the 5th of May, right? So it brings together the macro data with the hospital-centric data and creates a triage. Again, this is not something that is incredibly earth-shattering, but it's surprising how many health systems are really struggling to normalize the data that is coming out from health agencies within their context, right? And then we added a little bit of, because you're a machine learning and AI company, it would be unsaid if we don't do a little bit of that. So what we are doing is we are doing stateless services to, do a little bit of simulation, saying, if you could add 10 more beds, what would that mean for your peak capacity? How many ventilators would you need at your peak, right? And just play around with a little bit of math here and there. As you can see, this is from, St. Luke's out in Pennsylvania. This, we presented this publicly yesterday, so I'm happy sharing this. But you can literally go down to a campus at for beds, for wards, and so on and so forth, right? So it really gives people a good sense of how to plan for this. Now that said, most of New York doesn't need this anymore. They have perhaps seen the peak of this. The West Coast doesn't need this anymore, but the country of Chile needs this, right? They have not yet been hit by this, or certain counties in South, certain counties in Midwest might still need this, right? And it might not need this for this cycle of COVID, but it's a good thing to think about as we wait for the next earthquake to hit us, right? But then bringing it closer to the patient. So we went from a macro to a hospital level to a patient level, and again, what we have done is we have taken a lot of payer data, working with the state agencies, as well as EMR data, move that onto Azure in a standard FHIR format, and then overlaid CDC's guidance, and all the stuff you see on the left hand side are the guidance from CDC, saying if this is the precondition, here is the risk, right? So that administrator can basically create cohorts saying, can you find me that 70-year-old who has diabetes and asthma and lives alone somewhere, right? Can I reach out to them and then point them to the Microsoft Health Bot or point them to a better patient engagement tool? Because I think what people are realizing is that the flattening the curve happens after things go sideways. The best way to deal with the curve is to get ahead of the curve and make sure that those at risk are given care and given guidance before bad things happen to them, right? So so that's sort of step one of really responding to this in a more coordinated fashion, where it's just not the nurses and the doctors at the bedside fighting it, but also the the care managers and the patient engagement team working on this to make sure that the search really doesn't hit the ED, right? Everybody did not come to the ED, right? There are triaging options to do that. The problem is you don't know who to triage, right? Because people panic, people get on an ambulance and show up, right? So how do you kind of manage that? How do you coach people to say, here are 7 options. ED is one of those 7s, and you might come to ED when you need to, but before that, there are 6 other things you got to do, right? So just helping triage that using social determinants, using prior health records and that sort of stuff, right? Very simple to set up. As you can see, the data powering this is really data from claims and EMRs with prior health history flags and just CDC guidelines. We are creating cohorts. This is on Power BI, so literally you can talk to this piece of software, and even if you don't have SQL skills, you can just get a subset of patients that you need to reach out to, right? So that's what's happening outside the hospital. I'll move our focus a little bit to what's happening inside the hospital, which is sort of a trench warfare right now. So what I told you about was supply chain. Now we are going to the trench warfare, right? And what we have stood up. I'm going to talk about the word real time many times, because I think all this data that we need is there with the health system. The problem is it's not in front of the doctors and the nurses when they need it, right? The hospital is just basically telling us, saying, look, I don't have time to go look inside my EMR and update this, right? That person who was on ventilator has now stepped down, so that ventilator is available. It's in room 7, bed 14. My second floor team doesn't know about that ventilator's availability. Can you help solve that, right? And this is very tactical, and the reason you will see a lot of tactical response to this is because we have been working with the doctors at UW Medicine, the CMI at St. Luke's and elsewhere, where they're literally saying, look, I don't want anything complicated. I just want simple stuff that I can use right now because I really need that ventilator. Can you help me solve for that, right? So it's not AI in its massively meta state. It is very tactical. It's very here and now and useful. So the 3 things we are doing here: bed management, patient tracking and patient discharge planning, and then ventilator tracking, right? As you can see, for bed management tool, we are essentially using teletracking. We are using the denominator from EMR, and as hospitals are adding more beds, we are just using teletracking data to update that. But that's the denominator side. On the numerator side, as to how many beds are available at what point in time, instead of relying on the EMRs to feed us, we are directly latching onto the ADTs and the HL7s and using Azure API for Fire, bringing it all together and just standing this up on a Smart on Fire app in front, right? The good thing is, because it's all on a standard format, on a standard data pipeline, we can essentially roll down to a ward and roll up to a campus, to a system, to a state. And hopefully, if CDCs and the federal authorities are working on this very closely with the state governments, hopefully this can also roll up to a state level view at some point in time. We work with the Ministry of Health in Singapore and some folks in Sweden. In other countries, they have been able to do this, right? In US, because of our structure of healthcare, it's difficult for us to do that. But for what it's worth, at least at a system level, we can do that. Hopefully, in Chicagoland, with what the mayor is doing there, we should be able to do that for a city, at least in the next couple of weeks, working with URASH and a few other partners out there, right? So that's the bed management part of it. There is a very similar view of ventilators, saying what ventilators available where. Right, and we are going deep on the EMR feeds, the SIUs, the ORMs, the ORUs, where possible, taking data out of flow sheet, because for those of you who deal with these systems, how complicated this and painful this process is to do on a real-time basis, right? In supply chain or a retail or a hotel industry, this is pretty par for the course, right? Exactly how many towels you have for tomorrow, right? Unfortunately, we don't have the same rigor for ventilators, right? So, but we are trying to patch this together with HL7 feeds, just tracking this, making sure, if a ventilator is taken out of circulation for the next 2 days, that's the nurse doesn't have to run up and down to get hold of one, and vice versa. If a ventilator comes online and somebody has been taken a ventilator, we can make that available for the system for somebody to use it immediately, right? So that's what on the ventilator side. This is little heavy from a slide perspective, but this is a bedside huddle tool that we have put together on Teams. What it does is it essentially tracks which patients are in the hospital, and we are listening into the lab results coming in, and so that we can update, and the bedside team can take the decisions. We're doing very similar logic on length of stay and discharge planning, because what we are seeing, using Chicago or New York as an example, is that they are essentially creating new ICU beds and creating new step down destinations. Like right? Saying, if you don't have to be in an acute care or ICU, you can go to the step down destination and recuperate there, and then you can be discharged, right? So how do you manage that process? How do you know who you have to send where, who you need to keep, how many people you have, how long are they going to stay? Again, in peace times are generally, stable problems to solve, but in wartime, situations are changing every 30 minutes, right? So just reacting to this, bringing together data from EMR, bringing together data from EDTs, HL7s, and just standing this up together, right? So, and as you can see from the commentary down below, there is a lot of, other data from data sets you're bringing, like lab values and this, that. So all this coming together in a standard format has really helped us quickly on top and create new views on new predictions, whatever the nurses and doctors want on top of it, right? So that's the application scenario. I want to kind of quick do a shout out how you can get this presentation, Carson. I'm hoping we can make this available broadly, but this is available right now on Azure Marketplace as a Microsoft first party service, where if you are a Microsoft customer, you can literally get this for free against your enterprise agreement and go. And we have made this free for 30 days. We are trying to make this free for 60 days. And after that, if you don't use it, you don't pay a dime. If you want to use it, we are happy to help and figure out how to, make this work for everybody, right? The good thing is, even, whether it's COVID or no COVID, in this process, we are bringing together a lot of, data from different places onto Azure in a standard format, which I am already seeing for at least health systems in Seattle. There's, look, we have seen the worst of COVID, but this has taught us some lessons, right? I want to do a lot more with the data that I now have to work off, right? And I anticipate that to happen when hospitals kind of get their heads out of the COVID situation. They will take a more strategic view on what this means for their survival and what this means for their data strategy, right? So again, this is a step in that direction. This is not a silver bullet. At the very minimum, it puts together this, which is architecture. What we and I'm going to, for those of you on the call who have a technology bent of mind, what we have done is taken the best of Azure services, working with HealthNext, package them up in Azure Container Service. All this you see in the center is in a Azure Container Service that brings the data in a file format. We use Databricks for the ML side, and this gets deployed inside our customer partners Azure tenants, so no data leaves them. KenSci or Microsoft, none of us take your data. That all stays with you, but it stays inside your Azure. And then there are agents that we have built using Azure Data Factory and Azure Databricks that essentially latch on to the legacy sources, does the conversion, and moves them into Azure API in a file format onto Azure, right? And then the front end, as you saw, we have put together Power BI, Smart on Fire, and Teams, but the handshake here is at an API level, right? So tomorrow, if you want to plumb this inside Cerner, you can very easily do that. If you want to plumb this to Teladoc, you can easily do that. It's just an API that we can send over to somebody else, right? So that's sort of the architecture of what we are doing here. I don't want to spend too much time on why we're able to go live in 48 hours. The simple answer is, the infrastructure is pretty standard. It's deployed as infrastructure as a code, so nobody is tooling around trying to optimize this or that. So that's one part. The second part is, for most newer EMRs, the HL7 feeds are pretty standard and up to snuff. For older EMRs, some assembly is required, but again, it's just XML work. It takes a little bit of time, but I have seen amazing collaboration from every layer of the partner ecosystem as well as from the hospital, right? So I think it's not an unsolvable problem. It's just a problem where somebody says, okay, I got time to solve for this now, or I don't have time to solve for this now, and I will solve for this after I have taken care of this COVID situation, right? So so it's we are literally taking 1 or 2 health systems live per week, sometimes more. So, and I know that this is helping people, right? So I've my final comments here would be this, right? Saying it's our privilege, all of us from Microsoft and KenSci on this call, to be able to contribute to what is going on right now, right? Most of us are working around the clock with doctors and nurses trying to help them. We are here to help. If we can help, we would be happy to, right? With that note, I will pass that on to John and Carson for closing comments.
Yeah. So Carson, if you don't mind, I'd like to add a couple things and then I can push it over to you. So Microsoft has actually been building capabilities inside of our cloud business. We have this massive cloud that we build for every industry. And those assets are doing amazing things in other industries, but we've been building on-ramps for those assets to be used in healthcare. And I think what Sunny just showed you is a great example of those assets being utilized to fight a common cause, which is to go after this COVID thing, to basically join together as teams and defeat this enemy, if you would, or at least put a boundary around it for a while until it comes back again, and then know how to do it better the next time. I guess that's probably a better way to say it than defeat it, because I'm not sure we're going to see it go completely away. We'll just control it better, if you would. And so I think it's fascinating. Things like the FHIR interfaces and stuff like that we've been building, we're actually starting to see a lot of that work that we've been slaving away at come to fruition. And this is a great example of how you can actually leverage all that to help with the fight. And so with that, Carson, I'll push it back to you. It's been great. Thank you, Sunny.
Thank you, John.
Agreed. Before we start to close, I'd love to get a feel if there was any questions that anybody had while we are on today. Feel free, as this session is recorded, please feel free to reach out to me directly if you'd like to get a copy. I also have a copy of the slides that were shown today, so happy to share that as well. Furthermore, if you'd like to have a dialogue with Sunny, with the KenSci team, or with John Bartow, feel free to reach out to me as well, or engage your account team. We're happy to help in any way possible. Certainly, again, I want to echo Sunny's sentiments from the onset of this call. Really appreciate the hard work that you and your colleagues are doing in light of this pandemic to fight this enemy, and definitely look forward to working with you in any capacity we can in order to be an ally in the fight. So thanks for the time today. And with that, we'll go ahead and sign off. Again, please feel free to reach out if you'd like to continue the dialogue or get a copy of the recording. Thanks so much. Have a great rest of your day.
Thanks, everyone. Take care and stay safe.